Welcome to Around Town, and we are at Nash UNC Healthcare. I always like to say UNC part of it too because it just adds a whole additional layer of expertise being brought into our community. We already had a wonderful hospital, but now with the partnership, and I'm sure we'll be talking about this, but it just gets better and better. And we are so really fortunate as a community that that's transpiring right for us, for better health care for us. Kenneth Mullen, who many of you probably recognize, been around Rocky Mount how many years, Kenneth?
All my life, Jenny.
All your life. You were born here?
Yes, ma'am, I was.
Oh, great. But we're going to talk a little bit. You called me because you wanted to talk about the Patient and Family Advisory Council, and you're serving as chairman of
yes,
that.
Ma'am.
But the fact that you retired as a city employee, fire department, and served us all well there, and now are giving back even more, I think is very much of an example that we want to hold up to say, okay, everybody, this is our town, we love it, let's all jump in and do great things like you're doing. So
exactly,
thank you.
Jean. There's so many things that we know about our community that we're able to share with not only people who have recently moved in, but we're also able to share our expertise and some things that the city taught us as a member of the fire department that I'm able to bring to Nash as far as relationship building, things that we did within the organization. So very similar organizational styles, but yet totally different in what they provide. So anything that our community members can give back, I think that's our responsibility to do that.
Well, I do too, but I'm really appreciative of what you're doing.
Well, thank you, ma'am.
And Amy Wyndham. Amy, you have one current position, you're transitioning into another. You want to tell us what those are?
Sure. I am currently the administrative director of the emergency department and have been in the emergency room for 2 years. But I am in about 2 weeks going to be transitioning into a new position here in the hospital. It's called the Director of Service and Operational Excellence. And my primary job is going to be what Kenneth was talking about. In fact, we were talking earlier, is about building those relationships with patients and families, building relationships with each other as co-workers and colleagues, building relationships with the community in an effort to look at always improving the patient and family experience here at Nash. We provide a superior patient experience, but there's always opportunity for improvement, especially with the competitive world out there now among all the hospitals, since we're being now paid or penalized based on our outcomes and our performance scores. So, there's no more status quo. The bar's always going up. And so that's going to be my primary focus, is really looking at opportunities to improve the relationship so that our service delivery continues to get better and better.
Well, and I want to encourage people when they have an experience with the hospital when they come here, because things are getting better and better. And I know with our new chief nursing officer, she has a history in shortening times in the emergency room. She has a history of retaining staff. So, hopefully we'll continue to see improvements that Leslie Hall began, but now, we'll just see them getting better and better. But give good reports, give good ratings to the hospital. And I can say that. Y'all, I think, aren't allowed to say that, but I can. If you had excellent care or really good care, rate the hospital, because it helps them get better when they get those ratings. That's kind of our responsibility as the public.
One of the things we recognize, Jean, is that, and of course it's a human nature thing, that when we're in the moment, there's a lot that we recognize and a lot that we say, well, this could be better, or this was really good. And when we get away from that moment, we forget, or we just move away from it into another part of life, and we forget to share those good things.
Right.
And it's very important that while it's fresh in our memories, whether it was a good or bad experience, that we share that, so either we can let our people know how good they're doing or make improvements, because that's part of what I think our role is to look at those type things. Part of the mission here is to provide service in a caring manner. So we want to focus on that, and that's what the Patient and Family Advisory Council does, is focus in on, we kind of drill down in some areas and say, okay, we could do this and make the experience a little better. We were talking earlier, possibly a hospital stay is much like a person that needs a fire or police response. that could be the worst day of their life. And it's very important that we all recognize that, and we do all we can to make that experience one that is not something that is looked at as a bad experience, but something that's looked at as a good experience. And that's what our efforts are through the Patient Family Advisory Council. And Amy's I call her our leader, and she's very passionate about that and making sure that that happens here at this hospital. So we try to support her as much as she supports us in our efforts and what we're doing.
And kind of give us the background of the formula. How long has it been in existence? I know the hospital was built in 1971, and Bryant Aldrich. I mean, this, folks, you may not realize this, but this hospital was the first in the state to have private rooms.
I know. I think that is so awesome. It's nice to be able to say that.
Oh, it is. And also the day hospital, was that the first that had day surgery?
That's right.
And not spend the night? So we've got a lot to be proud of.
We do. And sort of the origination of the Patient Family Advisory Council, I would say it was back in 2012. We just sort of did a self-reflection as an organization, and we had heard about hospitals who practiced under a patient family-centered model of care. And of course, as a hospital, we would say certainly we were practicing under a patient family-centered model of care, but back at that time, the Chief Nursing Officer, Leslie Hall, and I attended a national conference to sort of understand what sort of designates or defines an organization as hospital and patient family-centered. And what we have tried to build, and obviously having people like Kenneth involved, is that truly looking at the patients and families as true partners in their care, true stakeholders. You know, they're as much of a stakeholder as anybody else of the healthcare interdisciplinary team. In other words, we need to have them participate in their care, share information about their care. And a way we like to put it is that it's not about what we do to and for the patient and family, it's what we do with them.
I really like that.
It's what we do with them. And I always, if I get a chance, and I do this a lot at hospital orientation, is that, and I think we all probably have stories that we can tell about this, is that when patients and families come into our hospital who are suffering, you know, as healthcare providers, we see what I describe as a 4x6. A picture of that patient and family. That patient and family has the whole picture. And so if we don't involve them in their care then and treat them like partners in their care, then we are minimizing what we know, and we're actually minimizing what could be the best thing for that patient and family throughout that continuum of care. So we have to get their input and treat them as if they're partners in their care, because that's really the only way that we're going to provide the type of experience that's going to be meaningful and valuable to them.
And a patient advocate for patients coming in too are very important. I've been a patient advocate for a number of people, but if anybody can always kind of even preemptively designate, if anything ever happens to me, will you be my patient advocate? Will you go in because you know my background, you know if I'm not able to speak, if I'm not able to communicate, you can fill in the picture.
That's right.
But Amy, one thing I'm thinking of, not only are they partners with you, but when they leave, they need to be engaged in how they can help themselves with continuing the benefits and the wellness that hopefully was achieved on their behalf here.
That's right. And the better job we do on this side of that experience as far as educating them and explaining to them, and it goes back to what you said about we need to hear from them about their experience, because if there was something we did well, we need to be able to spread that to the other areas. If it's something that we need to improve upon, we need to know it so that we can look at opportunities and create action plans that, off of that. So it is about continuous improvement. And you know, I think we also know that the perception of the patient and family is often different than the perception of the person who's providing the care. You know, we are often quite consumed with providing the skilled care. You know, are we putting the IV in right? You know, did we put the dressing on appropriately? Did we give them the medications that they were supposed to have? But you know, patients assume we're doing all of that correctly. Patients really are more concerned with how we treat them and how we make them feel. And so that's why, again, it goes back to relationships, establishing those relationships and seeing things through the eyes of the patients and families. They've taught us so much already, the council, about perspectives and perceptions and how we can change things that make it a better experience for the patients and families.
It's interesting too, Jean, to me, being from the public service side of everything, is that to open up your organization. And that's basically what they've done. They've allowed us to come in, volunteer
Tell us what
people.
you do.
Well, we meet once a month, and we've done lots of, our first major task, I consider it a major task, was, and we'll talk about this a little later, I'm sure, is people don't understand what a hospital physician is, what a hospitalist is. When they're admitted in the hospital, where's my doctor? You know, we expect our doctor to come. But the whole model of patient care, once you're hospitalized, has changed to include a hospitalist. We've looked at that. They've opened it up to the point that we've looked at procedures, we've looked at policies, we've looked at, last week, a couple of us were involved in a meeting to decrease the wait times in the emergency room. We realize that that's an issue. They could very well bury their head in the sand and say, well, that's just, it is what it is. But it's not. So they have taken the...
They really do care.
Oh,
here.
they do.
They want to
really
make it
do.
as short as
But
possible.
what people don't understand, Gene, and what we've learned in preparing some of this information is that there are over 70,000 people a year last year that came to our emergency room.
Wow. Is
And
that
I say
about 200 a day?
That's about
That's right.
200 a day. And when you start, and they come for any variety of reasons, and our emergency room, as I understand it, within the UNC system, and there are 11 hospitals within that system, we are the busiest of any of the 11 UNC
we
systems.
do.
And it's hard to imagine that right here in Rocky Mountain.
In peaks and slow times too, it's hard to staff because all of a sudden there could be a horrible wreck
Exactly.
on
That's right.
I-95 and major traffic coming in with people in life-threatening situations. And I know we're not a trauma center yet.
Right.
I hope we get to be eventually.
But my whole emphasis on that is, and what I listened to last week, in fact, was the fact that all of those disciplines have to come together. The physicians, the PAs, the nurses, just all the disciplines that are involved in a person's care, and they have to come together. Well, they're all doing that most of the time under emergency situations. So in order to have that come together and be able to provide the level of care that we want to provide here at Nash, that's a tremendous opportunity to let people know what our hospital is about. But yet sometimes it's looked at as, well, I had to wait 3 hours. Well, you may have had to wait 3 hours, but the person that comes in behind you may have a true medical emergency.
Maybe dying.
That's right.
Yeah.
That whole team then has to come around that person. I learned a lot sitting in that meeting, just listening to the providers talk. So yeah, we've got work to do, but I can see their heart, I can see their passion for wanting to get people in, get people out. That's what we look at as lay people. But their emphasis is on not only getting us in and out, but also providing quality care while we're here so that we don't have to come back.
Absolutely. We need to take a quick break,
Okay.
and we're going to pick right back up on that excellent point when we come back. Stay with us, please.
Hi, I'm Richard Koss, Pharmacy Manager at Allman's Drug Store at the Westridge Shopping Center. Here with my wife, daughters, and my business partner, Brad Hilton, and his wife, Katie. We are delighted to be new business owners living in Rocky Mount and are excited about the new services and products we are adding at Allman's Drug Store's 2 locations. With a full-service pharmacy, a large supply of over-the-counter supplements, and a comprehensive line of diabetic supplies, Allman's has you covered. Our pharmacists also specialize in consultations. We want you to pay the lowest prices and get the best service in town, and our staff works hard to help you save money, but we are also big on friendliness and customer care. We will deliver your prescriptions free, have drive-through windows, and guarantee short wait times. And we come out to greet you personally and see how we can answer all of your questions. Because as local business owners, we care about you. As a loyal member of your community for over 70 years, you can count on Allman's Drugs to make the health of you and your family our top priority.
Please call Almond's Drugs today.
443-3138.
Thank you for staying with us. Kenneth and Amy at Nash UNC Healthcare. Kenneth, I think some people watching might think, well, gosh, I would like to serve on the Patient and Family Advisory Council. What are the qualifications to do that?
I think the first thing, first of all, is just have a passion for wanting to serve. It's a volunteer position. Amy will talk about the criteria behind how you actually get on the team, but as an individual on the advisory council, I just feel like you have to have a passion for wanting to help people, want to serve. That's number one. And number two is have a concern for overall patient care. This is not just about me. And to look at it from a standpoint, you could very easily try to get on the council and then just focus on what your issue is. But this is a huge operation in patient care that I think, first of all, be a volunteer, have a heart for it, and then want to be involved in helping provide better care for our patients.
So one doesn't have to have been a patient recently or a family member of a patient recently in order to transition into doing that.
We like for that to happen, but it's not necessary.
First-hand
Certainly,
experience.
if you've had a person, if you've been a patient, or if you've been a family member of a patient, recently is good because it's all fresh in your mind. You know, you have ideas of what you would like to do, or would like to express in those meetings. But we've got a very good council, a wide range of cares and thoughts, and people that have actually been in the hospital as well as just family members. So we've all we're a wide range of people in that. We need some more people.
We do.
We really need more people.
We're a very diverse community,
That's
so we
right.
need some
Yeah.
diversity.
And we
too.
definitely want a diverse council.
Exactly.
You know, we have 8 active members right now. Really like to have about 15 to 20. And then as we grow, many hospitals then break off and actually have councils within different service lines. So like an emergency department, Patient Family Advisory Council, a women's center, Patient and Family Advisory Council. That's the vision. But certainly on this core group right now, would love to have about 15 members. And I mean, I probably couldn't cover it any better than what Kenneth did. Just people that want to be team players. And the beauty of understanding patient family centered care is that everybody has either been a recipient of medical care or has a family member who has. So everybody can comment on an experience, whether it was positive or negative, whether it was at Nash or not. So, you know, somebody that can speak to those experiences and provide valuable feedback. The process that we use is that if we find that someone is interested, or if thus far we've used staff within the hospital who have recommended people that they know in the community, then we just send a letter. It's actually Mr. Tuning, on behalf of Mr. Tuning, inviting them to be a patient and family advisor. There is an application, just so that we have that and understand who it is that we're looking at joining the team. And then we have a little subcommittee that just interviews each candidate, just to get to know them and kind of make sure they understand the council and let us get to know them. But we hadn't turned down a council member yet, so really, it's a wonderful opportunity for someone who has a heart for patient family centered care and that is committed to the community. I was born here as well, so you know, I have a strong passion for connecting with the community and understanding the importance of the hospital connecting with the community, and this is one of the best ways that we can do that. So.
Kenneth, when I asked you, and you sent me a wonderful presentation you had that you gave to a Rotary Club here, and you listed a lot of areas of consideration. You mentioned a little while ago about hospitalists. Tell us why that has ended up being an important aspect of the hospital, to have hospitalists.
One of the things we realized, Gene, was that a lot of people you don't just come to the hospital. It may be a once in a lifetime experience. And when you come, the old traditional model was that when you were admitted to the hospital, your physician, which I refer to now as a primary care physician, would come and visit you after he closed his office. It might be 7 o'clock, or first thing in the morning.
Do his rounds.
Yeah, he would do rounds. And most people that come into the hospital, they still look for that. And what hospital care has evolved into a hospitalist or hospital physician, which is a specialist in the field of caring for people in the hospital. So what our council discovered and thought was that not many people know this. When they come into the hospital, they still expect to see their doctor. And that just doesn't happen. So we began to look at it and say, well, how many hospitals are actually doing this? You know, is Nash out here by itself? But what we found was 89% of hospitals with over 200 beds have a hospitalist program.
And it's better care. It's continuum of care. It's not better than what your own private doctor can do, but with the shortage in primary physicians and the fact that they're tending to other people all day, every day, in the middle of the day you might need them. And to have somebody there who's consistently there, and they communicate with your primary doctor too.
Right. This is 24/7. The hospitalist is on duty. I think they work 12-hour shifts, Amy, is that right? 12-hour shifts. But you have that same doctor for like 7 days before they rotate in, and you'll have another. But the good part about it is that they can order tests. They can read tests as soon as they're available. You don't have to wait for the traditional model of your doctor rounding at 7 o'clock at night or 7 in the morning. And if other tests have to be done, then they can order those. And it takes people getting used to. Nobody likes change. We talked about that a lot. But one of our first goals was to get information out about what a hospitalist is. And we're calling that, Where's My Doctor? So we've done a brochure. We've put this presentation together. We gave it, first of all, to the management staff that Amy worked so closely with. And they approved it. And week before last at Rotary was our first time to get out with it, and now we're talking with you, so we're hoping to get it out in the community so people will better understand what a hospitalist is. And you don't have a surprise when you come in, and I love my primary care physician, but he's not going to come see me. That's just not the model of hospital care that we have now.
And the model of being that way, since 74% of our population are Medicare recipients, that's what they knew the majority of their lives.
Exactly.
That's right.
So when you look at that, and also they're more likely to be the ones who would need to have the help of a hospital as they're getting older.
And it does have a sort of, again, talk about the continuum of care, is that when we're discharging our patients from the hospital, they need appointments at the primary care physicians' offices to follow up so that they can be seen timely for their follow-up and managed outside of the hospital, because we're all in this together to help prevent readmissions or prevent them from maybe not getting the type of medicine or the prescription or whatever other intervention they may need. This allows the primary care doctors, and like you said, there is a shortage of primary care across the nation. In fact, there's lots of provisions in the Affordable Care Act that is providing resources to provide more primary care, especially in rural areas. It's a big concern, but to be able to keep them in the office so the patients can have appointment slots so that they can see them in a timely manner. The other thing that has been really an awakening for us here in the hospital when it comes to hospitalists is that research has shown and evidence has shown that there are many medical conditions, the quicker you get to the patient and the quicker the intervention, the more likely they're going to survive or that they're going to have a better recovery, a successful recovery. For instance, patients who are having heart attacks or strokes or patients who are septic. It's the time where the physician or provider does have to respond more immediately to the bedside to be able to provide that intervention. And again, if we're only rounding at 7 o'clock in the morning or 7 o'clock at night, it just makes that probability of them getting to that bedside less. So having a hospitalist here who can come when they're called, code sepsis, code STEMI, code stroke, outside of the emergency department up on the inpatient areas, it's just really valuable to have those. That's right, life-saving to have those resources.
And it's not only just a general hospitalist, Gene. That we also now have surgical hospitalists, we have a surgeon here, and a pediatric hospitalist, because we place so much emphasis on our pediatric care. So as it evolves, we evolve as well. And we as the patients have to recognize the fact that Nash is looking at the best possible care that we can have, not only in hospital care, but also our heart center, our women's center, our pediatric center, our emergency department.
And now Lineberger, we're getting we have an employee
Exactly.
from UNC
Yep.
Lineberger here,
Yeah.
Dr. Austin Johnson. So,
That's right.
I mean, folks, this hospital is just providing more and more services, specialized services. I mean, I heard of somebody who came in presenting with a heart attack, and because the UNC cardiologists were up there, the interventional cardiologist, he had a stent put in and had no heart damage. So the things that can be done here
That's
now
right.
are just marvelous.
Exactly.
But we do need input of people like
That's
you,
right.
so thank you.
Absolutely.
And we
Thank
also
you.
need y'all to come back because we didn't cover everything we wanted to. We want to talk about Medicare next time you come, but we're out of time. But thank you, and again, if you're interested, they can even call the hospital and say, I'm interested in serving on this panel, can't they?
Absolutely. If they can just be asked to transfer it to me, and we can get the conversation going and expedite their service on the team, because I just cannot express how valuable it's been and the appreciation I have for this council and what they've done for this hospital, partnering with us to provide that excellent service delivery that we need to do and that we can do and that we are doing. So.
Thanks to you.
Thank you, Jean.
Great volunteer.
appreciate
We
it.
like that. And thanks to you. Have a wonderful day.